set that to record. We're trying that. Again, if you have any questions or issues, go ahead. I have the chat box open. I can see it, so just put any questions there. And I think we are at 7 o'clock, so I'm going to try to keep a good, healthy pace here. Again, any questions, let me know through chat, and we'll get going. We'll start with the Genodermatoses, the first one on my list here. So we're going to start with the Ichthyosis, and what better place to start with Ichthyosis vulgaris, which is the most common type. We have an autosomal dominant condition, which can be associated with atopic derm, and defects. The causes are defects in filaggrin synthesis. The good news is it actually has a lot of similar morphologic features to acquired ichthyosis. So under dermatopathology, the two are essentially identical. As I was testing this thing this morning, this Zoom thing, I think there's like a couple second lag, so I'll just try to work with that. So bear with me if things are going a little off sync, just let me know. So we'll move on. Pathologically, the Ichthyosis vulgaris is kind of the one that we can sort of identify with somewhat good confidence, because you have, compared to the other ichthyoses, a loss of the granular layer, decreased granular layer, which you don't really see in the other ones, which are more increased. You also get things like compact hyperorthokeratosis, flattened reedy ridges, and follicular plugging. Clinically, ichthyosis means fish scale, so all of them have that in common, and you can see that represented nicely here in these clinical photos, this kind of fish-like scale. And Ichthyosis vulgaris tends to involve more the extensor surfaces and spare the flexural surfaces. This is in contrast to some of the other ones. Here it is sparing these flexural areas. This is a schematic kind of showing what I was talking about, how you get this compact hyperkeratosis and a decreased granular layer. I'm going to keep stressing that among the ichthyosis, decreased granular layer, and also a follicular plug to boot. Another one. You also tend to get a little bit of a sort of flattened reedy ridges, which is in contrast to some of the other ichthyoses. So before we go there, this is a Pat presenter, which is very good. They have a nice collection of these unusual dermatoses, which are can be hard to find because they're all rare. But this one is Ichthyosis vulgaris, and if I'm looking at this power, I mean, I always tell the residents, start from the top down. What do you see abnormal? And don't neglect the stratum corneum, because it can tell you a lot. And this one we have, this is not normal. This is not basket weave. This is compact hyperorthokeratotic, or what I call ichthyotic stratum corneum. And it's a really good clue that tells you that you're dealing with probably an ichthyosis. I've heard sometimes they put this ichthyoses in the invisible dermatosis category, which I think is fair. But here, that really jumps out. It's got that really red, sort of flattened, reedy ridges as well. And most importantly, you look at that, you can hardly see a granular layer throughout here. So get a little closer. Kind of all reduced to nothing. So that's the one thing about this Ichthyosis, Ichthyosis vulgaris, that kind of stands out. So try and remember that one. We'll move on to the X-linked recessive ichthyosis. Here are the salient features. Obviously, X-linked recessive affects males, steroid sulfatase deficiency, and more involvement of flexural areas, at least in comparison to Ichthyosis vulgaris. Here we have some clinical photos. Again, more involvement compared to vulgaris of flexural areas. And if you see here, we have more of a retention of the granular layer compared to Ichthyosis vulgaris. Oops, let me go back. So let's go to Path Presenter, and here's this low power of X-linked ichthyosis. And I'm going to be talking a little bit about lamellar autosomal recessive ichthyosis. To tell the difference between the two histologically can be very, very difficult. So that's why I was focusing more on telling the difference between these and Ichthyosis vulgaris, because these, in particular, this one, X-linked ichthyosis, has more of a retained or thickened granular layer. You can see it right here. The reedies tend to be more preserved as compared to Ichthyosis vulgaris. But you still have that ichthyotic scale. It's like that red, compact hyperkeratotic scale. If I were looking at this and I didn't know anything else about the biopsy, I would say that, well, I got to focus on this because there's something wrong with this scale. So nothing else going on in the dermis. Again, classified as this sort of invisible or whatnot dermatosis. Okay, so let's go back here. Move along to the keratinopathic ichthyosis, epidermolytic ichthyosis, which I actually learned as bullous congenital ichthyosiform erythroderma. And all of these that are listed on here kind of have the same pathologic feature, ichthyosis on confetti, or superficial epidermal lytic ichthyosis, or ichthyosis bullosa. I've seen as they have like a million names, which can drive me crazy. That's just the way it is. But the thing that it's important to know this one, because the thing that they all have in common is a very, very characteristic histopathologic pattern, probably one of the most characteristic patterns of the ichthyoses and of all of dermpath. And we'll get to that in just a minute. So focusing on this one, the new name, epidermolytic ichthyosis, you can see that it used to be called, as I said, bullous congenital ichthyosiform erythroderma. And this is the key right here. You see epidermolytic hyperkeratosis. I always tell residents, try to recognize the pattern. Try to understand there's only limited numbers of inflammatory patterns. And if you can get it, you can always kind of classify in your mind, you're limited to just a few disorders, of which this is one of them. So epidermolytic ichthyosis will show epidermolytic hyperkeratosis, autosomal dominant involving keratins 1 and 10, and extensive epidermal nevi with EHK. These patients can be at risk for transmission to a generalized pattern. Okay, and this is what I was talking about. Epidermolytic hyperkeratosis is the pattern that you'll actually see under the microscope for these conditions. So the most important thing when you're on your dermpath rotation, just be able to recognize this pattern, because then you can correlate it with the clinical scenario and get your diagnosis. It's a very common pattern, but actually what we see it most is incidentally, but you can see it in association with what we're going to talk about, epidermal nevi, some keratodermas, and solitary lesions, epidermolytic acanthomas. So here's the clinical for this epidermolytic ichthyosis. Pretty striking clinical photos here. And then here is the pattern this is the most important part, the pattern that you want to recognize. You have this granulization and vacuolarization of the upper portions of the epidermis. And I think we have one here we can show. So here we have on Path Presenter this. At this power, you can tell, I mean, this is an epidermal process, and you can see that bubbling, that granular kind of degeneration, vacuolar degeneration up in the spinous layers. Very, very characteristic pattern. And again, most of the time, what I see in practice, it's kind of just an incidental finding, but it's good for the residents, for anybody to recognize this, because you will see this pattern. You'll definitely see this. They'll definitely ask you about this. It's got this kind of purplish look to it. It's a problem in keratin development, and you can also develop quite a bit of scale too. That really nice vacuolization and granular change. Okay. Any questions so far? All right. Can everyone still hear me? I'm not talking to a void, am I? All right. We'll move on. We'll talk about the autosomal recessive congenital ichthyosis. This is also formerly known as the harlequin ichthyosis or lamellar ichthyosis, or the non-bullous congenital ichthyosiform erythroderma. Autosomal recessive, it's essentially a clinical diagnosis. You can get severe thick plaques, and this is the one associated with the collodium baby, which is a very striking clinical presentation. Mutations in transglutaminase or other genes. Some clinical photos. And then here's the collodium baby. Here's just a schematic showing the difference between vulgaris and lamellar ichthyosis. And it's really the difference between ichthyosis vulgaris and all other ichthyoses, except with the one that has epidermolytic hyperkeratosis. You can see the decreased granular layer and the sort of the flattened reedy ridges right there as well. Some syndromes with ichthyoses, I'm just going to mention these just for completeness sake. Netherton syndrome, where you can have this ichthyosis linearis circumflexa. I don't have a slide of this, but I can show you a photo in a second here. This SPINK5 gene encoding LEKT1. This is new, actually. This is in the textbooks, in the skin pathology Whedon textbook, they talk about this being now almost like the gold standard of diagnosis. We can actually do immunohistochemistry for this LEKT1 gene product. But as far as what you see under the microscope without the immunohistochemistry, it's pretty much just a psoriasiform pattern for this Ichthyosis linearis circumflexa. So it can be sort of, if you have it in the right context, you can suggest it, but otherwise it's pretty much, you're gonna have to do the immunohistochemistry, you have to correlate it to really get to the diagnosis. Refsum disease, I'll just mention briefly. I don't have any images for this, but it is one of the ones that can have ichthyosis in it. I don't think we need to go through the laundry list here, except just to say that you can have lipid vacuoles in the suprabasilar cells. Wish I had a photo of this one, but so unusual, we could not get one. Here's a few other syndromes associated with the ichthyosis: Sjogren-Larsen syndrome, Conradi-Hunerman, trichothiodystrophy, and Child syndrome. It was a real challenge trying to get through this, all the names and pronouncing them right, I'll tell you. Other disorders that affect keratinocyte differentiation: erythrokeratodermia variabilis, progressive symmetric erythrokeratoderma. And again, these have non-specific histology, so I'm not going to spend a whole lot of time on this. Okay, so we'll keep a brisk pace here. Moving on to the Palmar plantokeratodermas. I'm going to go through each and every one. No, I'm just kidding. I'm not going to go through all of these. This is a table from Lever, and it talks about, it's actually a nice table because it really talks about, from a dermatopathology perspective, what we can expect to see. And you can see right here, anyone that has this diffuse pattern clinically, you're not really going to see a whole lot histopathologically. Basically, you're just going to see a lot of hyperkeratosis. So these are all clinical entities. There's a few that do have that epidermolytic pattern, though, that we just talked about. And I mentioned keratoderma as being one of the things that can have epidermolytic hyperkeratosis. So that's good. And there's a few punctate ones, which do have somewhat of a characteristic histologic finding, and the porokeratotic ones, which we'll talk about. So the diffuse keratoderma have similar histology, as I just mentioned, except for the epidermolytic variants and the porokeratotic variants. And this is the punctate one I was just referring to, the keratosis punctate palmaris et plantaris, some of which have involvement of the AAGAB gene, and we'll get to that one. And I'll show it because it is something that could probably show you on an exam and say, well, what could this be? You see, it's very characteristic. If I see this kind of without knowing anything, I can tell, well, it's very thickened skin. It's got a lot of hyperkeratosis. It's very thick epidermis. It looks acral to me. It looks like acral skin, which it does turn out to be. And it's got this very peculiar hyperkeratotic plug right in the center here. Common, I would start to think about things like a clavis or a corn, which is what you would see on the soles of the feet. But then you correlate it with the clinical findings, and it turns out that this is actually punctate keratoderma. Here's another image. We'll flip this on like this. So it's pretty characteristic, and that's why I'm showing it, because this is something that you could be quizzed on. If there's a lot of parakeratosis, and if you have some of the characteristic features of cornoid lamella, you have more of that dell at the bottom, then you can start to think about punctate porokeratosis. Okay. Questions so far? Can somebody please just type yes if they can hear me? I don't want to keep talking
I can hear you.
Oh, excellent. Okay, good.
Hey, Joe,
Thank
you're doing
you.
a good job there.
Sorry, say again?
I said you're doing a good job. I can hear you.
Thanks, Brian. I just want to make sure I don't keep talking for an hour to nobody. All right, I'm going to keep talking about Pachyonychia congenita. I'm not going to say a whole lot about this. Just to tell you that the pathology can show some hyperkeratosis and intracellular vacuolization. Again, no slide for this one. Pathology somewhat, not really all that 100% specific, so I don't think they would ever show a slide of this and expect you to answer what it is. This is something they could, though. Acrokeratoelastoidosis, autosomal dominant condition. I've seen one case in the last 5 years or so. And this they could ask you because it has elastorexis and a very distinct kind of clinical presentation. This sort of linear yellowish papules distributed at the sides of your hands or feet. And then we have, good histopathologic picture right here, where you see almost again like a cup-shaped depression and sort of this hyperkeratosis. But you wouldn't be able to make the diagnosis just from this. Again, I would be thinking, you know, common things, clavis, corn, and that sort of thing. But you really want to do the elastic stain, and you would expect to see a decrease in elastic fibers, which I have a photo actually of right here. This is from Whedon's Skin Pathology, showing the decreased papillary dermal elastic fiber and the decreased deeper reticular dermal fibers, and maybe even some fragmentation. So elastorhexis, basically. All right, we'll move on to the porokeratoses. Another pattern, we talked about patterns, the epidermolytic hyperkeratosis pattern. So now we're talking about the porokeratosis pattern, because this is also a pattern that you will see and they'll probably be asked about at some point. And you want to recognize that pattern because it can correlate to many things. It's actually a clonal proliferation of abnormal keratinocytes. You have the different conditions for porokeratosis, the Mabelli, the DSAP, disseminated superficial actinic, linear punctate porokeratosis, which I just briefly talked about, plantaris, palmaris, and disseminata. So the cornoid lamella, I just talked about it being an important pattern, but it's not 100% specific to porokeratosis. It's necessary. You have to have it to call porokeratosis, but you can see cornoid lamella in other conditions as well. We'll get to that in a minute. So let's go look at this is an example of disseminated superficial actinic porokeratosis. And this is what we see. Often we see a shave biopsy. And if you're doing a shave and you're suspecting poro, please get the edge of it, because this is where the diagnosis lives, right here and over here. I'll get a little closer here. This is our cornoid lamella. So if you don't get the edge of the biopsy in poro, you may not get the diagnosis, or we may not be able to get the diagnosis for you. The center can actually look a lot like a lichenoid keratosis. You can have brisk lichenoid infiltrate, and if we miss this, we can't make the diagnosis. But this is our cornoid lamella. I kind of think of it as sort of this perikeratotic column stabbing down into the epidermis. You sort of get this dell, and you sort of get these necrotic keratinocytes. You really have to have this picture right here. Columns of perikeratosis by themselves are not enough, because you can see this in actinic keratosis, but you really want to see that pushing down into and these kind of dyskeratotic cells in the superficial portions of the epidermis. Some cases you can have these cornoid lamella involving follicular structures as well. Here's a follicle right here with a nice cornoid lamella. All right, good. So we'll keep moving. Any questions so far? Okay, so we'll go on to, let me take a drink of water. We'll go on to congenital bullous disorders. So basically we're talking about epidermolysis bullosa here. So here is another chart from Lee versus histopathology of the skin. And this is really, again, it's like the keratodermas. I'm not going to go through each one of these, but you kind of get a sense over here at the gene product, understanding what it is that each of these, if you break them up into the simplex, the junctional, and the dystrophic, what they involve. The simplex tends to involve these keratins 5 and 14 with a smattering of others. The junctional tends to have this laminin and alpha 6 beta 4 integrins. And then the dystrophic tends to have the type 7. There are others, but that's in general what you see. And I also tell residents, make sure you have your favorite chart that depicts this, because if you understand what's going on at the junction, you will understand a lot of dermatology, not just in bullous disorder, but immunobullous disorder and just in general. So it's a really good idea to have that understanding. And so this is where junctional epidermolysis bullosa simplex lives. Junctional lives here, and then the dystrophic lives down here. 18 genes involved, so there's plenty of board material. Kindler syndrome is also thrown into this as well. So simplex is intraepithelial, and that's kind of the point I want to make, because it is something you could probably suspect just from looking at the biopsy, and it generally heals without scarring. And then if we look at it, we have one example here, I think, a couple actually. So here's a biopsy that shows a split, and you may think, well, it's subepidermal, and it is kind of subepidermal, but if you actually look closer, you can sort of see remnants and splitting that's going on right here within the epidermis itself. Simplex can be pretty much at any level of the epidermis, and if you see areas where you're suspecting it could be within the epidermis itself, you're probably dealing with simplex. Here's another one actually. This one is not quite as good. This one really looks subepidermal to me, but if you look closer also, you can see that there's something going on right here, maybe the beginnings of a split within the epidermis itself. So then that puts you in the category of intraepidermal splits. And then here we have some photos from Wiedenwitter, much better because you can see actually the remnants of the basal layer right there. So it's an intraepidermal split in simplex. And then here, even better, you got a more higher up split right here. Junctional, you have the split through the lamina lucida involving the hemidesmosomes. In some cases, you can get scarring, and you have risk of squamous cell carcinoma. And then here you see more of this clean split without anything involving the epidermis. So this is junctional. And dystrophic, you'll have also subepidermal, but you usually have much more severe involvement, scarring. This is the one that has that characteristic pseudosyndactyly, which we'll look at in a second, and you can have recessive and dominant variants. So here's a pseudosyndactyly, which is a very impressive clinical presentation. And the split, again, subepidermal with scarring. You almost always will see scarring in dystrophic epidermolysis bullosa. So as far as how to biopsy, you want to biopsy from an induced blister, actually. That's the best way to come to a diagnosis. And you want to do ancillary studies as well, whether you need transmission electron microscopy or immunofluorescent mapping, which I'll show a little bit here. So immunofluorescent mapping basically just takes the split and then takes antibodies to different elements of the junction and sees where they are. So this is an example of dystrophic epidermolysis bullosa. And you can see that these are BP180 and laminin, which are on the roof. And dystrophic, everything's gonna be on the roof because the split is so low. If we look at our map here, we can see it's way down here, collagen 7, and all of these other antigens are gonna be up there. So any antibodies to those antigens are gonna be high up. So that, again, that goes why it's so important to have a good understanding of this, this junction, a map of this junction in your mind. And you can do that for all of them, and by process of elimination, narrow it down to either simplex, junctional, or dystrophic. All right, we'll move on. We're making good time. About a half hour gone through. Any questions so far?
For Jim, for simplex, sometimes trauma blister can look like that as well. You know, you can get an intraepidermal split like that. So
yeah,
yeah, exactly like that, like EB simplex.
Yeah, that's exactly what I was thinking.
I've seen these things missed because it comes in and it's, you know, a child, and it's a small amount of lesion. It comes in as trauma, and it's undiagnosed simplex.
Yeah, it's a very good point. Very good point. As a matter of fact, it's one of the things in differential is the level of the split for friction can be right in the middle.
Right.
The epidermis, just like that. So good. All right, we'll keep going now. So the next thing I'm going to talk about is familial benign pemphigus, or Hailey-Hailey disease. Probably see this at some point throughout your residency, maybe several cases. Autosomal dominant involving the ATP2C1 chromosome or gene on chromosome 3. I heard, I always get this mixed up with Darier's disease, and I heard somebody say something about how to remember this. It's, I want to see Halley's Comet someday or something like that. It's kind of silly, but it actually works for me. So we'll talk about Darier's in a minute too. This is an ADP-dependent calcium transport. Intertriginous areas, you get these large kind of flaccid bullae. And the differential diagnosis histopathologically is going to be these two things, are the big ones really, Darier's and pemphigus vulgaris. Okay, so let's go to our slide here for Hailey-Hailey. And the first thing I notice here for Hailey-Hailey is that it's in the family of this acantholytic disc keratosis, but it's really more on the acantholysis side as opposed to being on the disc keratotic side. Darier's is more on the disc keratotic side. And Hailey-Hailey also involves really the whole span of the biopsy that you're looking at. It's one of the more, that has extensive involvement, acantholysis of the whole breadth of the epidermis. And of course you get your classic description here, the dilapidated brick wall, which kind of actually looks like it pretty good right there. Pemphigus, I mentioned, was also a differential, one of the things in the differential diagnosis. And one of the things they talk about in the difference between Hailey-Hailey versus pemphigus vulgaris is that Hailey-Hailey will spare or tends to spare more the follicles, whereas vulgaris will involve the follicles. Plus vulgaris, pemphigus vulgaris will have more of an infiltrate with eosinophils or eosinophil exocytosis, that sort of thing. So you can see right here in this example of Hailey-Hailey, you don't have involvement of the follicles. So I thought that was a good representation of that. But this is a pattern you'll want to recognize, this acantholysis. You can see it in a lot of conditions, and you will definitely be seeing it when you do your derm path rotation. And in addition to Hailey-Hailey, you can see it in other conditions, as I just talked about. And you can see it incidentally. You can see it in warty disc keratomas. Probably the most common scenario, again, is incidentally that we see it. All right, so now we'll move on to Darier's disease. So Darier's disease, autosomal dominant, keratotic papules and palmar pits, nails with longitudinal ridges and distal defects, white plaques in the mouth, and acrokeratosis verruciformis of Hoff, which is kind of, I put a question mark there because it's a little controversial whether it belongs with Darier's disease or not, but we'll go ahead and talk about it. The histology is a little bit different from what we see in Darier's. It's more of this church spiral keratosis. I'll show you the image of that. So here again, it's not the Halley's comet, it's the ATP282, which enclosed the sarcoplasmic endoplasmic reticulum calcium pumping protein ATPase, or SERCA2, on chromosome 12. And more of a seborrheic distribution, really nice example here of this seborrheic distribution on the back as well. And if we look closer, or if you have the chance to palpate these lesions, they really feel very keratotic. You can see right here, they're kind of individually placed and they're very keratotic. So what I was saying earlier, where Hailey-Hailey is more on the acantholytic side, that's why you get those large vesicles, bullae. It's more of a flaccid disorder. Darier's tends to be more of this kind of keratotic thing. So you'll get, it's more on the disc keratotic side. And I'll show you that histopathologically. Here are the palmar pits and the longitudinal ridging on the nail. And then histologically, this is what I mean. So you do get acantholysis, but you get a lot more of this, the core rons and core grains, and this hyperkeratosis, parakeratosis on top, which gives it that rough appearance or a rough feeling. And here again, the core rons are these larger ones right here. The core grains are the more parakeratotic ones, like the grains of rice right here. Another one. So we'll get to, let me show you an example first. This is acantholytic disc keratosis right here. I don't even think this was an example of Hailey-Hailey disease, or sorry, of Darier's disease, but it still is. If I saw a biopsy like this, I would not be able to tell you whether or not this was Darier's disease. I mean, this could be an incidental thing. It would have to be correlated clinically. But you see how compared with Hailey-Hailey, this has much more of that kind of discrete, sort of micro-lacunar type vesiculation as opposed to broad vesicles, a lot more keratosis. That's why you get that keratotic feel on palpation clinically. But you'll still see the core rons and core grains. You see the acantholysis here. You can see the core rons right here, and the grains are the smaller parakeratotic ones. All right. And again, acantholytic disc keratosis, like the other patterns, like the cornoid lamella, epidermolytic hyperkeratosis, is one of the major patterns that you will see and need to recognize. And here's all the things that we can see this pattern in. And again, most commonly, I see it incidental finding. Although the other day I just had a warty disc keratoma, and we'll see that again soon. And then again, before we leave Darier's, acrokeratosis verruciformis of Hoff has that church spire pattern, which not specific, but it is an important pattern to recognize. You can see it not only in this condition, but you can see it in things like, very commonly, seborrheic keratoses or acanthosis nigricans or carp. All right, any questions before we tackle mastocytosis? Okay, everyone still hear me? All right, so let's go on to mastocytosis. I'm going to be talking about just the cutaneous mastocytosis. Here we see some of the variants. We have urticaria pigmentosa, which is the most common. But to be honest with you, the one we probably see most often biopsied is TMEP, telangiectasia macularis eruptiva perstans. And this can be a very subtle diagnosis to make because it's the one that has like the least number of mast cells. You really have to have your radar up to make this diagnosis. And I'll show you an example actually later on. The diffuse cutaneous and the solitary mastocytoma tend to have many more mast cells to them. Eosinophils can often be a clue to this, so it's nice if you're dealing with the subtle ones like TMEP. If you happen to see eosinophils, that's a good clue. Now, of course, your c-KIT mutation, which corresponds to CD117 stain, which is a stain that we do immunohistochemically to identify these as mast cells. Some of the older stains have come up, it's kind of fallen out of favor. They're not used as much. The GIMSA, the leader, the toluidine blue, chloresteate esterase. Again, they've been more replaced by these more modern immunohistochemical stains, CD117 and mast cell tryptase, which is also a very good one. All right, so we'll go to the mast cell here. I believe this was a solitary mastocytoma, and you can see that it had this, kind of looks like a bird actually, but you can see the dermis is kind of being filled right here. And at this power, I know it's a dermal process. I know it's a diffuse dermal process. Something's infiltrating the dermis, but even at this power, you can still tell that it has that uniformity to it, to the nuclei. They're sort of the fried egg is the classic description of mast cells. And so if we go closer, you see all of these really round, regular nuclei. I think we may be able, the stain's not the greatest, but I think there may even be a couple eosinophils in here. So if you have any doubts, you can always do the immunostains. Sometimes these can be difficult to distinguish from like a Langerhans cell histiocytosis or nevi or xanthogranuloma, but all of those are easily distinguished by the immunohistochemical stain. Here's another example. This is more like when you see this big Goomba like this, and it's in the context of mast cell disease, you're probably dealing with a mastocytoma. And then here we can see the same morphology. It's really the same cells, this very kind of cuboidal uniform look from field to field. Very round nuclei, very fried egg. I think that's actually a pretty apt description of these mast cells. Some can even be bullous actually. Here's an example of a bullous mast cell process where you get weakening at the dermal epidermal junction and vesicle or bulla formation, but the same process really. You see mast cells are right here, maybe not quite as nicely stained as the other ones, and you see eosinophils, often a good clue. Eosinophils intermixed with the mast cells. Okay, questions about this? Okay. So ectodermal dysplasia, I'm not going to talk too much about. There's 200 clinical conditions, which I'm very happy I don't need to know, but you probably need to know a lot of these, or maybe not all of them, but just know that the old way of distinguishing them was hydrotic and anhydrotic forms. I think that's kind of falling out of favor now. Variable hypoplasia of the hair and sebaceous glands. This involves the hair, teeth, nails, and sweating. It's really mostly a clinical diagnosis. The histopathologic correlate is actually almost nil. Decreased number of hypoplasia of sebaceous glands and hair follicles, decreased sweat glands, and we're not going to say too much more about that. We will talk about Incontinentia pigmenti. The X-linked dominant condition mostly or usually involves, almost always involves females. Mutations in the IKK gamma gene are part of the Nemo complex, and you get these linear vesicles, verrucous papules, and whorled pigmentation. And here we see this nice clinical photo showing exactly that, almost like a vesiculation here, a very Blaschkian kind of distribution, maybe areas of pigmentation right there. Again, a linear or Blaschkian kind of distribution to this, maybe some hyperpigmentation. And this has, it progresses through stages. So the first one is this sort of eosinophilic spongiosis with a lot of exocytosis of eosinophils. Really, it almost looks like you can think of a contact or bite, arthropod bite. It's very hypersensitivity looking. And it progresses more to this kind of papillary thickened hyperkeratotic process. We get this strange kind of dyskeratotic cells. You get a lot of dyskeratotic necrotic individual keratinocytes, which is, it's a very kind of distinctive, unusual pattern that you don't often see combined. So let's go to our photos here, our slides here. So here is one that has much more of this spongiotic or early spongiosis pattern. And again, if I saw this, I see spongiosis, I see microvesicles, I'm thinking common things common, I'm thinking eczema, I'm thinking contact reaction, I'm thinking maybe a different type of hypersensitivity. Then you might tell me, well, this is a young patient and, you know, it just looks funny. Well, then I start looking a little closer, maybe start looking for things that are unusual. And we see eosinophils, which still could go for a contact, but we also see a lot of necrotic keratinocytes throughout here, which is a little strange for a contact reaction. And as you kind of progress, here again, this is another example, almost with vesicles right here. These are all eosinophils. But as you progress to the more advanced stages, you can get this sort of a picture where you get less spongiosis, but a lot more of these necrotic cells. And, you know, I don't know if you can see them, but they're kind of peppered throughout here, throughout the epidermis. And then here's a better probably example. I'll get close right here. Yeah, this is a better example. I'll get close right here. You can see this individual necrotic cells. So this is a really peculiar pattern. In a kid, you would really be suspecting Incontinentia pigmenti because of this. I don't know what else you would think about when you get this many necrotic cells. And you also have a little bit of pigment incontinence right there too, starting to progress the third stage, the pigmentary stage. Then finally, you get the more thickened stage, and you still have a few necrotic keratinocytes here, but you can see how much more thick the epidermis has become, and you really don't have as much spongiosis like you had in the initial stages. All right, any questions about that? Are we doing on time? Okay, we got 7:40. We're actually doing pretty good. All right, so then I'll talk a little bit about aplasia cutis congenita, a heterogeneous group of disorders that does have sort of a histopathologic correlate that's not 100% specific, but, you know, I could see them maybe throwing that on an exam and asking you if they provided clinical context what this is. You have a localized absence of skin, and like I said, not the most specific histology. I do have, I think, a picture right here. So here's a biopsy that shows an absence, basically, just an ulceration sort of, missing epidermis right in the central portion of the biopsy. And you have more than just that, actually. You have really an absence of adnexal structures too. You can see them over here on this side, and you can see them over here on the right side. But right in the central area, you have an absence of those structures. So that might be a little bit of a clue that you're dealing with something more than just like a traumatic ulcer or something like that. But other than that, you're not going to be able to tell a whole lot. By looking at this, I could probably tell it's kind of got that bright red fibrillar collagen. Maybe it's a kid. So then you might start to think beyond just the usual causes of ulceration here. But other than that, you probably wouldn't be able to give a specific diagnosis. All right. Questions before I move on to the DNA repair disorders? Everyone's still hanging in there? All right. So we'll move on to the DNA repair disorders. This is another one I just kind of want to try to conceptualize as much as possible because I can't possibly go through every detail on each one of these. I've been to the Dominican Republic. They have a clinic out there for a lot of the poor population in Santo Domingo that deals with a population that has xeroderma pigmentosa. And the general kind of think about this is that this is a very photosensitive disorder, a defect in DNA repair, and these patients can get some very, very bad aggressive melanomas or other types of skin cancer. But in the context of what we're talking about here, we're talking about poikiloderma. We're not going to talk about the melanomas that you see with this. We're not going to talk about the squamous cells because the histology of those are just going to be like any other melanoma or squamous cell carcinoma. But in the context of DNA repair disorders, we will talk about poikiloderma because that is kind of the binding theme of these conditions that I'm about to talk about. Here is a photo of a patient with xeroderma pigmentosa, and you can see it's got a very disfiguring, very unfortunate disease for this patient. Here's another one, keratosis congenita, which has a lot of features, but we're going to be talking more about the reticulated poikilodermatous and hyperpigmentation pattern. Rothman-Thompson is another one. Photodermatitis and poikiloderma is what binds these things in common, and Bloom syndrome. So this is what I'm talking about. This is the clinical presentation. In poikiloderma, you basically get presentation with erythema, mottled pigmentation, epidermal atrophy. You can see another photo right here. This is obviously a child, and it has the skin that looks beyond her years. And here's another one showing the more erythematous. So here's an image of poikiloderma, not the best one. I actually have a good image right here that we can look at. So what is poikiloderma? Because that's what's binding all of these conditions together. And it's not wanting to load up now. Okay, well, I guess we'll go back to our image. We can't get, oh, there we go. Thought we weren't going to get the slide to load. But here what we see, and one of the things I tell residents for these subtle things is that look for the areas where it's normal. And often at the edge of the biopsy, you can see nice basket weave keratosis. This is what we kind of reference ourselves. We say, okay, this is what the patient's normal skin probably looks like. And then we look towards the center of the biopsy, and this is where the abnormal part comes up. And so now it makes it a little bit easier to our eyes, now that we've calibrated our eyes to the normal, to determine what is abnormal. And what is abnormal? Well, look at the dermis right here. The papillary dermis kind of changes from this normal to this more fibrotic with vascular ectasia, maybe a mixed inflammatory infiltrate. Look at the thickness of the epidermis. It goes from relatively normal over here to thinned out over here. And this is really the essence of what is poikiloderma. It's a pattern where you see epidermal atrophy, maybe a little bit of interface change, necrotic keratinocytes, and you see maybe some melanin incontinence, this sort of, I kind of think of it a little bit like basal cell stroma in some ways. You get this fibrotic telangiectatic stroma with this mixed inflammatory pattern right here. So it's not, this is the only thing where you can get poikiloderma, the genodermatosis. It's one of the things, but you can see it in conditions such as mycosis fungoides and some connective tissue diseases as secondary response to radiation, cold and heat, sunlight, or poikiloderma savate, which is kind of this acquired condition where you get poikiloderma like around the neck area. So a lot of conditions can have this pattern, but again, like I've been saying before, recognize the pattern and then correlate it to the clinical context to get to your diagnosis. All right. And then for completeness sake, other DNA repair disorders, Lever talks about Ichthyosis, telangiectasia, Hutchinson-Gilford progeria, and progeria, the adult Werner syndrome. No real specific histopathologic correlate. Okay, any other questions before I move on? We're almost at the end here. Could somebody please type yes, because I feel like I'm talking into a vacuum. Yes, thanks, Joe. Excellent. Okay. Disorder of connective tissue. So let's talk about Gold syndrome, because Gold syndrome, I kind of feel like it's a board's favorite because it can always show some impressive clinical photos, and the derm path correlate can be pretty striking as well. It's also known as focal dermal hypoplasia, the PORCN gene, excellent dominant. And the key is you see these atrophic skin with yellow nodules. This is the protrusion of the fat, actually, which we'll get to in a minute. In addition, you can have malformation of the digits. You can have what's called a lobster claw, or the very characteristic osteopathia striata. So here's the clinical photo of what Gold syndrome looks like. And we do have a histopathologic correlate. And I think the residents always say fat up high in the dermis, which there's a differential for it, which is good, I think. And often I hear nevus lipomatosis superficialis as being one of the things in the fat high up in the dermis. And it certainly is in that differential, but I think it looks really different because in Gold syndrome, it really is this kind of atrophy of the dermis, of all the adnexal structures and everything right here. It almost looks like it's gotten squashed. You really don't see that in nevus lipomatosis. You kind of see more of a robust dermis, a normal dermis. And in Gold syndrome, all of the fat is kind of pushed up to here, and it herniates and creates those lesions that we were just looking at clinically. So right here, this is all hypoplasia or hypodevelopment of the dermis and the adnexal structures. This one actually shows it even better. Let me orient this one. So you can see, here's the fat, and look at this. You can see these eccrine structures all kind of pushed up over here. Really not much dermis to speak of. It's like everything's just refused to develop. So that's one I think is fairly specific histopathologically. I think they could show you this image, and you should be able to get the diagnosis from that. All right. Finally, we're gonna, last few things here. Pseudoxanthoma elasticum, a very important one, a very good histopathologic correlate here. This is an autosomal recessive disorder. You get involvement of areas that have a lot of elastic tissue. So in addition to the skin, you have ocular involvement, you have cardiovascular lesions. The Bruch's membrane of the eye has a lot of elastic fibers, so you get angioid streaks. The aorta does as well, so you get atherosclerosis or arterial rupture, and also the GI tract. The ABCC6 gene is the important one to know. And here's this kind of characteristic look on the neck, actually, which we'll look at the histopathologic correlate now. I have some good examples of this one. So this is one that you can recognize, or you should be able to recognize and diagnose histologically. Certainly as pseudoxanthoma elasticum-like fibers. Now you can't necessarily make the diagnosis of pseudoxanthoma elasticum because you can have pseudoxanthoma elasticum-like fibers in other conditions, but you can certainly make the diagnosis that these are pseudoxanthoma elasticum, at least like fibers. I hope that makes sense. If you do a von Casa stain, you can see some calcium in these, but it's very characteristic. It's like this kind of curly, short, frayed, basophilic elastic fibers, often in the reticular dermis, not so much in the superficial papillary dermis. In some cases of this condition called acquired pseudoxanthoma elasticum, you can have perforation actually, almost like a perforating disorder. So a very characteristic look, and actually I've seen pseudoxanthoma-like or elasticum-like fibers in secondary conditions like in scars. You can see them sometimes secondary things in lichen sclerosis, even in like things like basal cell carcinoma. It's been reported in granuloma annulare. So you can see the fibers as a secondary phenomenon in a lot of things, but they are still characterized all the same. They still all look the same, and you can still call them pseudoxanthoma elasticum fibers. Here's another example. So I would not be surprised if they showed you this on your board exams. Again, the short, curly, frayed look, which will state positively for calcium. All right, questions about that? All right, here, move on now to connective tissue nevi. So these are dermal hamartomas. They can be composed of collagen, elastic fibers, or a mixture of both. As a matter of fact, it's probably really hard to tell which component is which, how much it involves collagen, how much involves elastic. So I think people are just kind of starting to put these all together as one thing. You can have them solitary or multiple as part of a syndrome, like the Proteus syndrome, tuberous sclerosis, or a really important one to know is Whisky-Ollendorff syndrome. Here's an example clinically. Oh, wait, I have one, I think, image of this one. So this is a connective tissue nevi. I think this is also in the invisible or like minimal change differential diagnosis, which I think is a good place to put it because it is very hard to tell that there's something going on here. But if you've seen enough kind of normal skin, you start to recognize that this doesn't completely look normal. These bundles of collagen are kind of fascicular. They're sort of haphazardly organized. And as I was saying earlier, if you can find an area that's sort of normal, like at the edge here, this is kind of normal collagen. This is what it's supposed to look like. And you compare this side over here to this side over here, you can sort of start to see the difference between this down here to the lower right and then up here on the upper left. So you may at least start to suspect that there's something wrong. There's something going on with the collagen here, and start to suspect the connective tissue nevus. All right, I think I had one more image here. I don't think this one is as good. This one would be really difficult. I think I could probably stare at this one for a while and not really know what's going on. You could use your trichromin elastic fibers to see if there's some disorganization. And actually looking at this a little bit closer, there's something funky about these collagen fibers. They're just kind of disorganized. And it just comes, I think, from seeing a lot of normal collagen. You start to be able to know what normal is supposed to look like versus abnormal. And here, if we move off to the edge, I don't know if anyone can appreciate, this is normal. So this is what normal collagen is supposed to look like. If we go back to that other area, you can see right here, this sort of thicker haphazard arrangement of these fibers compared to the other ones. It's subtle. Okay, so then Ehlers-Danlos, I'm not going to talk too much about because there's contradictory findings on histopathology, so there's not going to be a whole lot we can do from a light microscopic perspective. Cutis laxa is something that you can actually see some changes under the microscope. You get redundant or pendulous skin, congenital or acquired, autosomal dominant or recessive, and it affects the elastic fibers. In some cases, you can have visceral involvement, but basically what you see is a loss of elastic fibers in the papillary and reticular dermis. I have this image from Whedon. This, I couldn't tell you if there's anything wrong with this. This is the normal histology, a routine H&E. But you can do an elastic stain and you can see right here that there is actually a loss and fragmentation of elastic fibers, which is in the right context, fits well for cutis laxa. And then this one I'm just going to mention, pachydermal periostosis, just because it was last thing in the lever chapter. But as far as histopathology, really all you see is just thickened skinned fibrous bands extending into the subcutis and increased acid mucopolysaccharides. Couldn't find a good image for this one, unfortunately. This condition can be genetic or acquired, and you see digital clubbing with periosteal proliferation on the hands and feet, cutis verticis gyrata as well. All right, so in the remaining minutes, I have a few more unknowns that we're going to go through. And these are cases that are interesting from a variety of perspectives, but let me go through these one by one. So this is a case where we have, I look at this and I say, okay, there's this sort of downgrowth right here. And I'm thinking sort of warty disc keratoma kind of a thing. And if you remember what I said earlier about warty disc keratoma being one of the things that has acantholytic disc keratoses, and if indeed we do go to higher power, we can see these nice core rons right here and core grains. And we have this nice acantholysis right here. Really nice example of core rons right here, and core grains right here. So this is a warty disc keratoma, one of the conditions that can give you the major patterns we just talked about, the acantholytic disc keratosis. But there's 2 for 1. That's why this case is so nice, because if we look over here at the edge, remember I told you epidermolytic hyperkeratosis is the most common scenario that I see it in is as an incidental finding. And I think that's what this is here, because the main lesion, this was a solitary lesion clinically. The main lesion was this warty disc keratoma, and we happen to have incidental epidermolytic hyperkeratosis with this vacuolization right here in the spinous layer. Very, very nice example of a 2 for 1 right here. So the 2 patterns you really need to know right next to each other. Here's acantholytic disc keratosis on the right, and here's epidermolytic hyperkeratosis on the left. This was actually a nail, and what was interesting is that this patient had Darier's disease. I would have never gotten this, but this was a case we were able to pull from our files. And this is really hard on this biopsy right here, but you do see a few maybe acantholytic cells right here. And then they did a nice nail bed biopsy right here, which it shows it much nicely right here. This acantholytic disc keratosis, some of the core rons, not quite as nicely developed as the case I just showed you, but still enough right here. Here's the acantholysis. Here's maybe a few core rons and core grains right here. So very nice nail example of involvement by Darier's disease. Okay, and here is a lichenoid keratosis. No, of course it's not a lichenoid keratosis because that doesn't make any sense in the context of this chapter. But if we just had the central area right here, it sure looks like a lichenoid keratosis. It's not until you look at the edges. Remember I told you take that broad biopsy at the edge of a porokeratosis to be able to get that cornoid lamella right here. You can see that perikeratotic stabbing right here into the epidermis with individually necrotic cells right here in the dell right there. So here's one on this side. We actually have one sort of a poorly formed one, but I think this is actually all a coronoid lamella as well. It just didn't quite get as nicely formed as the one on the other side. And in the center, we have what looks like an LK, like keratosis. So this is probably best fitting for DSAP, disseminated superficial actinic. And here's a really nice example. Here's a nice coronoid lamella right there. Okay, another warty disc keratoma. And this one has an area, again, more of a endophytic growth. Sorry, we're getting a little bit slow on the loading of the slide. We may have to skip this one. Yeah, let's skip that one. I want to show you this one. This is actually a better one. So this is not warty disc keratoma or acantholytic, but it is something, there we go. So I look at this biopsy and I think, well, not a whole lot going on, very invisible. That's kind of been a theme of the day, that a lot of these cases that I've been showing you, the pathology basically just shows sort of this invisible or nothing, or you got to start going through your differential. I think I've heard Tim B. Tuck. There's all sorts of acronyms out there to remind yourself of what to think about when you have minimal pathology or invisible dermatosis. But I think if you squint a little bit right here, you can sort of make out this. There's just a little bit too much telangiectasia right here, vascular ectasia throughout here. So I think that that would be a first clue. The second clue, the next thing I would do is look at the clinical to see if this is a rash, what are they looking for? And if it is indeed a rash, I would go closer and examine the infiltrate. And there's something just kind of strange about these cells right here. They're a little bit more spindly out here, but they're fairly large. Some of them may be a little more cuboidal, on the cuboidal side, roundish side, maybe the ones down here. And I believe right here, you can see these kind of guys right here that has the very basophilic cytoplasm. So these are actually mast cells, and the clinical fit very nicely for mast cell, for TMEP actually. This patient had telangiectasias throughout, I think it was on her legs and lower trunk. So we go ahead and we have the mast cell tryptase stain, which you can see, don't be thrown by this background sort of light brown staining. You really want to see this crisp, dark brown staining that are lighting up these cells right here. And there's just too many mast cells here. So this fits really well for TMEP. And as I said earlier in the talk, TMEP, the mast cells in TMEP, instead of being that round fried egg look like we were seeing in some of these mastocytomas, they tend to be more spindly or fusiform looking. This really shows it very nicely right here. So TMEP is one of the subtle mast cell diseases that we see most commonly, but can be also very, very difficult to diagnose if you don't suspect it. And I think we had, I think that was it actually, because this is just another recut of the same TMEP slide. So any questions, any issues? I think I just made it over 8 o'clock. There was a lot to cover, and I know it was quite a marathon session, but I hope I was able to distill into the important derm path kind of high yield stuff, because I think that's the best we can hope to do in a genoderm lecture. Okay, excellent. I'm glad everybody enjoyed it. And unless there's any other questions, just have a happy, great Sunday and rest of the weekend. You're welcome.